Bismillahirrahmanirrahim. So, now talking about the alopecia. Alopecia can be classified as the one that has a scar or one that is not put a scar. There's scarring and non-scarring based on the present of whether the presence or absence of the permanent hair follicle damage. So, first of all, we need to know the hair follicle cycle. Now, the cycle starts from anagen phase, the growth phase, which is characterized by the elongation of hair shaft, active follicle, and dermal papillae is present. Then comes the catagen phase. Catagen phase is the transition phase in which the hair follicular activity cease, and then the telogen phase, that is the resting shedding phase, in which it separates from the dormant follicle and the dead hair falls out. Then the proliferation of keratinocytes will occur, which will removes the dead hair, and the dormant follicle will again become active and move into the anagen or growth phase. So that's the hair cycle. Now, anagen phase constitutes most of the um growth cycle of the hair, and that is 80 to 90%. The catagen or the catagen or the transition phase that consists of characterized by the regression and process of the hair follicles. The hair shaft may continue to be extruded from the follicle, but it's no longer growing because it is separated from the base. So it accounts for less than 1%, and the telogen phase, that is the resting or shedding phase, has variable duration. The hair shaft is shed during this phase in preparation for the growth of a new hair. Now, alopecia can be broadly divided into two categories, like we have previously discussed: the scarring one and the non-scarring one. The scarring one has inflammation and destruction of the follicles, like one occurs in the lupus, cutaneous lupus erythematosus, and the non-scarring the scalp is normal. There is no inflammation, and follicles are preserved. Now, this can be divided into focal and diffuse. The diffuse one is the one, the telogen effluvium. Telogen effluvium occurs in response to any kind of trigger, and that can be a pregnancy, any sort of physical trauma or illness, emotional trauma, thyroid dysfunction, and iron deficiency. The focal one includes the most famous one, that is the androgenic alopecia, the alopecia areata, the tinea capitis. Fungal infection can be scarring depending on the duration and severity of the trauma/infection. Syphilis and trichotillomania. Trichotillomania is a psychiatric disease in which the patient pulls his or her own hair. So there are hair follicles, hair shaft in of variable lengths, and the focal irregular areas of hair loss. Now, non-scarring and then the scarring. Alopecia may start as non-scarring and can become scarring, like the one that occurs in tinea capitis, and repeatedly or continuous inflammation or insult. Okay, so non-scarring alopecia, first of all, tucking hair loss in the following condition is reversible. However, if persistent or untreated, certain conditions like traction, alopecia, tinea capitis, trichotillomania may eventually lead to the scarring alopecia that is irreversible. Now, alopecia areata. Alopecia areata is autoimmune, and it is characterized by T cell mediated attack on the cells within the hair bulb at the base of the follicles, and those are responsible for keratin production and hair shaft elongation. Okay, so the T cells will attack the keratin cells. So, autoimmune attack on the hair bulb cells associated with other autoimmune disorders like hypohyperthyroidism, vitiligo. Now, what is the clinical presentation? Alopecia areata diagnosis is made by visual inspection, like with the dermatoscope. Painless, patchy, non-scarring hair loss, which will affect the scalp, face, or body. Exclamation point hairs, like small hairs with proximal tapering. Small hairs with proximal tapering may be seen. So management, what is the management? Mild to moderate hair loss, intralesional or topical corticosteroid therapy. Topical corticosteroid therapy that can be done because it is an autoimmune etiology. It has an autoimmune etiology. And extensive hair loss, oral genus kinase inhibitor like baricitinib, or topical immunotherapy like diphenyl cyclopropanone, and screen for autoimmune thyroid disease. So we need a thyroid profile, serum TSH, and prognosis. Regrowth is common in mild cases, and recurrence is common. So no point in like that's common. Next one. Complication, even with treatment, A has variable course with period of relapse and spontaneous remission. Hair loss often have psychological impact, and that's that. Now the one, the telogen effluvium. Telogen effluvium, hair follicle undergo widespread shift into the resting. We have studied the three phases: the growth phase, the transition phase, and the resting phase. So in telogen effluvium, the hair follicles go into the resting shedding phase, which is also known as telogen phase, with cessation of growth and subsequent shedding. It is often triggered by stressful events like severe weight loss, pregnancy, major illness, or surgery, psychiatric trauma, iron deficiency, and thyroid dysfunction. So, telogen effluvium, acute, diffuse, non-inflammatory hair loss, as compared to the alopecia areata, and scalp and hair fiber appear normal. Hair shaft is easily pulled out. This is a very diagnostic test of telogen effluvium. That is a hair pull test. Hair shaft are easily pulled out and trigger severe illness, fever, surgery, and all those triggers. Address underlying cause and reassurance, because it is a self-limiting disorder. And one more thing about this is, okay, so and now coming to the pattern hair loss, male and female pattern hair loss. Male pattern hair loss, that is an androgenic alopecia, and female pattern hair loss, both have variable presentations. Basically, they differentiate on the basis of the area they affect. The female and male pattern hair loss. The primary pathophysiology is follicular miniaturization, that is the shortening of the hair growth phase. Hair growth phase constitute of 80 to 90% of the cycle. When it shortens, so the total cycle will shift more towards this transition in shedding phase. Male, this is due to the dihydrotestosterone and genetically susceptible follicles, and woman, it is idiopathic, isolated, or hyperandrogenic state like PCOS. So clinical presentation, it is a chronic state, progressive hair thinning and shortening. Men vertex, the frontal hairline, and the temporal area, while the woman, the temporal area is preserved. It usually occurs only vertex in the frontal skull. So basically, alopecia, androgenic alopecia in female, it does not affect the hairline. It affects the frontal scalp and vertex. Management, in male, the management primarily include the I think that's zero point 0.1 mg finasteride tablets and minoxidil, 5%. And in women, it is 2.5% minoxidil. Telogen effluvium हो गया है, ठीक है. Now some pictures. Alopecia areata, patchy hair loss and normally appearing skin. There is no scarring. It is of autoimmune etiology. This is trichotillomania. Trichotillomania, as I've already discussed, it is a psychiatric illness. The patient pulls their hair. So we will see a patchy alopecia with hair regrowth of the various length. Going next, tinea capitis. Tinea capitis is a fungal infection of dermatophyte infection of the head. It will look like black dots. These are the broken hair shaft, and scalp erythema will be present because there will be inflammation. This is a more defined picture of the tinea capitis. Erythematous flag with scaling and hair loss. Now the traction alopecia. This one occurs in the patient who have like tight hairstyles, slick back hairstyle. That is due to hair loss due to traction generated by a ponytail. And this is the female pattern hair loss. As you can observe, there is preservation of the frontal hairline. It mostly affect the frontal scalp and the vertex, and it is a non-scarring hair loss of the vertex and frontal scalp. And one more important thing is It can be due to endocrine conditions or like PCOS, hyperandrogenic states. Androgenic alopecia, the greatest enemy of man, that is the frontal and temporal hair loss. And here you can observe there is a loss of hairline too, and hair loss at the vertex and mid-frontal scalp. Now there are the stages of androgenic alopecia. Stage one starts from the loss of the temporal area, then it it expands on the vertex loss, temporal loss, and the frontal loss, and then the vertex loss, temporal, and the frontal loss combine in the midway, and just the sideways or the lateral portion of the head, the hair is preserved on that area. This is we're going to talk about this is the type, the scarring alopecia. As you can see, this occurs in lupus erythematosus, SLE. This is called lupus erythematosus. There is permanent hair loss due to scarred scalp. No follicular ostia is visualized because the follicles are destroyed here, and hypopigmented erythematous scarred patch with hyperpigmented periphery. Another picture, scalous violaceous patch on the leg. So these were all the pictures. And alopecia areata, traction alopecia we've already discussed. Traction hairstyle like ponytail, braids, buns, dreadlock may cause follicular inflammation that lead to follicular miniaturization.